Hello, everyone. Thank you for attending today's webinar, Addressing the COVID-19 Crisis, an open forum webinar series for pharmacy. Today, we'll be speaking about meeting patients' needs for flu and other routine vaccination during the COVID-19 pandemic. We are also in our 50th webinar in this series, so thank you for joining us for these, if this is your first or if this is one of many that you've participated in. My name is Sandra Leal, and I'm the Executive Vice President for Tabula Rasa Healthcare, and I'm also the President of the American Pharmacists Association. I will be your host and moderator for today's webinar. I'd like to thank the CDC for support. This webinar is supported by grant number 6, funded by the CDC, and its contents are solely the responsibility of the authors and do not necessarily represent the official view of the CDC or the Department of Health and Human Services. So today, we are going to be discussing strategies and recommendations for providing flu and routine vaccinations during the upcoming flu season and the approaches pharmacists can use to reach patients who have fallen behind on routine adult vaccinations during the COVID-19 pandemic. So there's going to be a lot of great information shared today, and I just want to remind everybody that we have the handout with all the slides available to you on the sidebar. We have two great speakers that will be with us today. We have Carolyn Bridges, and she is the Director of Adult Immunization with the Immunization Action Coalition. She is a board-certified internal medicine physician who has worked on influenza and adult immunization issues for 25 years. She joined the Centers for Disease Control and Prevention in 1996 as an Epidemic Intelligence Service Officer, and later became the Associate Director for Science in the Influenza Division, and then the Associate Director of Adult Immunization. Her work at the CDC focuses primarily on influenza and adult immunization, policy, and implementation. She also worked as a volunteer physician at an FQHC for 20 years. So thank you, Dr. Carolyn Bridges, for joining us. We also have Steve Foster, and Steve's been a participant of these webinars for several times, so we thank Steve Foster. He is the APHA's liaison representative to ACIP. He's retired as a captain from the U.S. Public Health Service in 1998, as a professor from the University of Tennessee College of Pharmacy in 2016. He is a national faculty and writer for APHA's pharmacy-based immunization certificate training program and has been a featured speaker and author in many immunization education programs. Dr. Foster has personally trained thousands of pharmacists as immunizers, and through his work with student pharmacists has facilitated the vaccination of more than 10,000 Tennesseans. With us today, we also have subject matter experts, and this includes Mitch Rothholz, who's the Chief of Governance and State Affiliates at APHA, and he's also the Executive Director for the APHA Foundation. He brings a long history at APHA as our vaccine expert. We also have with us today Elisa Bernstein. She's the Senior Vice President for Pharmacy Practice and Government Affairs at APHA, and she brings over 30 years experience at the FDA. So we're going to review today's format for the webinar. We've just done the introductions, but we're going to have Dr. Bridges and Dr. Foster join us at 12:05. We will also have an open forum discussion after we have a discussion with them, where we will go through your questions and thoughts that you can plug into the GoToWebinar panel as you're hearing the discussion. And then at the end, for the last 10 minutes, we'll review on items that are going on at APHA and what's coming up next. So the open forum ground rules are, you just want to hear your questions, so please go ahead and include your questions in the question field on the topic that we're being covered here. Please include any comments or questions as possible, and we have the handout available to you in the resources. So what I'll do now is I will invite Dr. Bridges and Dr. Foster to join us and turn on their cameras to get started. Good afternoon, Dr. Foster and Dr. Bridges. Thank you so much for joining us today. Let's go ahead and get started. And I'll start with you, Steve, if you don't mind me calling you Steve.
Please do.
Can you tell us a little bit about the work that you've been doing on improving vaccine rates during the pandemic? You've been quite busy during this time.
While we have been busy, I'm not sure I'm doing a lot of getting these rates as improved as we want, which is one of our big discussions today. And by the way, good morning, Dr. Bridges. It's great to see you again. We have gone way back with ACIP activities and CDC. Most of my time has been spent with two things, really. Educational programs such as this is trying to get the word out to people through different agencies and different organizations. We do it. And realistically, attending a lot of ACIP meetings. We have had at least one a month, if not two a month. And it has been taking an awful lot of our time. And I also want to throw out to thanks to Dr. Michael Hogue, who also has been on our work group, on the COVID work group for the ACIP, and he has been meeting weekly through this whole time period. So it's been a lot of meetings, a lot of educational programs.
I'm sure. Thank you so much for your time in doing that, and also for doing this on top of that. So we appreciate your time. And Dr. Bridges, how about you? Can you tell us a little bit about your work during this time?
Yes, first, thanks so much for having me. It's really an honor to be here. Pharmacists are such a critical part of the response in so many ways, and thanks for everybody hanging in there. It's been a long year and a half. I retired from CDC at the end of 2017, and I moved back to my home state, which is in Idaho. And so during the pandemic, I've been doing a lot to support providers and officials in my home state. Given my background in influenza epidemiology and pandemic planning. And I've also been volunteering a lot at multiple COVID-19 vaccine and influenza vaccination clinics. So those have been very informative. And then through my work with Immunization Action Coalition, we've been working to help keep provider organizations and providers up to date on very rapidly changing landscape for COVID vaccines and other vaccines. And we also developed a website to help providers find resources for mass vaccination clinics. That's massvaccinationresources.org. And then in addition to all that, we've been really trying to help providers not forget about the many other vaccines that are recommended for adults. So thanks so much for having this webinar. It's on a really important topic.
No, thank you so much. We have so much information to share, so I'm excited about the updates that you have, and I'm taking notes too with the website you just shared, so thank you for that. So can you talk, Dr. Bridges, talk a little bit about the current trends in the routine vaccination rates during the pandemic? And I know we have a few slides that you wanted to share, so we'll go to the next slide.
Great. So this is just a reminder for all of you, you know this already, but there are 14 different antigens that are recommended to be given to adults based on age, as well as for the next slide on medical conditions, as well as other factors. So, we have seen some decreases in a lot of infections during the pandemic. Those are transmissible, but it's important to know that those trends are starting to go back up. So as people gather more, as they travel more, we're going to see a return very likely of many of the infections that we saw some decreases in. So we all need to get back in there and get those other vaccination rates up. So during the pandemic, we did see drops in the number of doses for routine vaccines that were administered to adults. And we have not seen the rebound to make up for that loss. So that's something really to pay attention to. So that drop in adult immunization really comes on top of already really paltry adult immunization rates. So adding insult to injury, we've got a lot to do to make up for those already low vaccination rates. So this is some data from even before the pandemic. This is actually the most recent data available on all adult immunizations. So from 2018, National Health Interview Survey that was just really recently published. And we find that for adults 19 and older, only about 1 in 5 is actually up to date on 4 of the most commonly recommended vaccines. So this is just looking at those proportion of adults that are up to date on flu, pneumococcal vaccine, shingles vaccine, and then the tetanus containing vaccines like Tdap. And even for adults 65 and older, less than 1 in 4 is up to date. So if you go to the next slide, please. And, you know, as we have noted, adult vaccination just really hasn't been something that is improved a lot over time. We have seen some small increments, but again, even looking back to 2010 up through 2018, we really see that a lot of effort is needed to improve these vaccination rates overall, and now on top of that to make up for vaccinations that weren't administered over the last year and a half.
Well, we have a lot of work to do then to catch up from previous levels, and now with this on top of that. So thank you for sharing. Let's go to the timing of vaccinations, and I'll ask you, Steve, what are the recommendations for this season's flu vaccine, and have they changed? I thought I saw something updating us on that. Can you share a little bit about the new recommendations?
Yeah, we spent, unfortunately, at the last ACIP meeting, we were able to talk about something other than COVID, so it was kind of interesting at that point. The one thing I do want to point out, though, is that we had a big discussion on flu, and keep in mind that even though we had a very mild season last year, it's going to be more difficult to get our patients to want to get the flu shot because there were very few cases last year. So we really needed to put a lot of effort into convincing our patients that flu shot is still around and it's going to continue to be around. It's not something that's going to disappear. In addition to the timing of vaccinations, we talked about what vaccines were available, what the composition of the vaccines were, some age indication changes. We're going to show all that just in a few minutes here. So speaking about timing, the one theme that came out during the ACIP meeting was the fact that protection wanes over the season. And so this protection, this waning, is more pronounced in older adults, particularly seniors. And it's not seen as much in children. So most of our suggestions and recommendations came about based on that. So for children that require 2 doses, it didn't really change from previous years. As soon as you get the vaccine, feel free to start on those children, give them their first dose now, and then at least 4 weeks later, or not at least, but after 4 weeks at least, give them their second dose, and that way they hopefully can get it done by the end of October. Now, children who require only 1 dose, make sure they get vaccinated by the end of October. You can go ahead and give them their dose earlier if you want to also, because as I mentioned, in children, they don't seem to have as much waning of the protection as we do with the older adults. Next slide. Then we talked about the adults also for the timing of vaccination, and one of the discussions was on pregnancy. The pregnancy discussion said that if someone is in their 3rd trimester of pregnancy, and during this time period, early after you when you get your vaccines, it's okay to go ahead and vaccinate that mother at that point, or that potential mother, because of the fact that she will pass immunity onto the baby, since the baby can't get the vaccine for the 6 months. So that's an okay to do that one early also for the purpose of protecting the infant. But I want to stress that for the non-pregnant adults, this was the big important change, and I think something that really needs to pay close attention to is that it said, and they got really strong on the wording this time, they said that vaccination during July and August should be avoided. Now, that there are cases, for example, that if you think the patient will not come back in again or will have trouble coming back in, yes, we definitely want to get them vaccinated. But for most purposes, if they the July and August time period, and we're already past the July basically, but for at least if you have the vaccine in August, wait until September before we start the routine vaccination of the adults.
Oh, that's good to know. Yeah, I haven't seen too much advertisement yet for the flu vaccine, but just wait as long as you can. Okay, beyond July and August. That's a great point to make. All right, so then we have a little bit of a question here related to just the availability of the flu vaccine and composition. What products are going to be available for administration this season?
This was a very nice slide that they actually presented at ACIP also, and it kind of summarized things up in a very nice way. First, we've got 4 standard, and by the way, I'll point out all vaccines this year are quadrivalent. So for the 4 standard injectable inactivated vaccines. We have 4 of them. They're all approved now to 6 months and older. We have the cell culture, which is approved. This was one of the changes that occurred this year, is that previous to this point, Flucelvax was approved for ages 4 and up. It's now been approved for down to 2 and up. And so we have another tool there, but this is a egg-free vaccine. We have still the 2 senior vaccines. Both of them are quads this year. So we have the adjuvanted vaccine and the high-dose vaccine. We have the recombinant vaccine that's approved for 18 years and up. And we also have Flumus Continue, which is approved from 2 to 49 years of age. So this is a good table just to show you what we do have available and what age groups that they should be used in.
Great. So all quadrivalents, that's interesting.
It took a while, but we finally got there.
Well, that's good. At least it's consistent now. It'll hopefully make it a little bit easier. All right, so let's talk a little bit about co-administration here, and I'll go back to you, Dr. Bridges. Can the COVID vaccine be given concurrently with a flu vaccine? I know that question is coming up a lot, and we've already had a little bit of information, but just any updates on that?
Yeah, thanks so much. That's a great question. Yeah, ACIP now states that COVID-19 vaccines can be co-administered. This is obviously after now having administered more than 300 million doses of COVID vaccines. So there's now a lot of safety data available on COVID-19 vaccines. And the standard of care for vaccines has always been that you can co-administer. So really was out of an abundance of caution that recommendation was initially made to wait 14 days before or after any other vaccine before you administer COVID-19 vaccines. That being said, there is not safety data really available yet. This one published on co-administration of COVID-19 vaccines with other vaccines. And so, that's a discussion to have with your patients. Make sure that they're feeling comfortable. And if you're going to co-administer, then, consider vaccination in different arms. And that is particularly going to be important, I think, for those vaccines that may be more reactogenic, for example, adjuvanted vaccines like the Genrix vaccines or high-dose flu vaccines. But, again, we have a lot of adults and a lot of children, particularly thinking about back to school, kids going off to college, my own son too, that a lot of us got out of our routine of getting those routine vaccines, those routine healthcare visits. And so, there are a lot of people who are behind. So to not miss opportunities, again, you can co-administer. For all COVID-19 vaccines that are given, we want to make sure that we're still encouraging patients to enroll in the VSAFE program, and then to make sure that, and to help improve the amount of safety data available, encourage all providers to make sure that they're still reporting to VAERS, the Vaccine Adverse Events Reporting System. So you definitely can do it. It is ACIP approved, but think about those vaccines that are more reactogenic and put them in different arms.
That's
I'd
great.
also like to stress one more thing, is the fact that don't avoid these reactogenic vaccines. If people need the vaccines, give them. Just be aware and tell the patients what might happen because of the increased reactogenicity, but don't avoid it.
That's great. We need to catch up. So we've got a lot of work to do. That's great. Well, this is great. I just want to remind people we have the slides with this information so that you can print it and have it available to you. Dr. Bridges, are there any vaccines that should be delayed? Anyone that you can consider? Or
Well, actually none. So the ACIP recommendations are pretty clear about that now. You can co-administer at any time with the COVID vaccines. But again, you just want to make sure you have that conversation with your patients and think about, particularly about those more reactogenic vaccines. And if patients are likely to come back and are motivated to get vaccination, you absolutely can delay. But there are going to be situations where people have limited time and they need to get as many of those missed vaccines in as you can.
Great point. Those are great points. Thank you. Let's talk a little bit about the discussions related to boosters or additional vaccines. And Steve, I'll go back to you on this question. What are you hearing about COVID-19 booster or additional shots, and how might the need for these vaccines impact the vaccine efforts this fall?
Well, I will tell you, we're hearing an awful lot about it, but there's a bottom line is that boosters are not approved to be given, and they should not be given at this point. I want to stress that before we talk about it. That doesn't mean that we're not discussing it, we're not bringing it up or talking about it. And it really is going to depend on two things. Is COVID going to be around in the same manner that it is now? Is it going to get worse? Or are we going to have or are we going to have waning of immunity as we do? There's some evidence. There was something that came out even I read today about the fact that there's a slight decrease in immunity or waning of immunity with Pfizer's vaccine as far as their effectiveness goes, but not a significant decrease yet. Probably not big enough for they can say, yes, everybody needs a booster. One among the discussions is that they might be talking about adults that are maybe the boosters might be for certain populations and not everybody. Maybe just people over 65, long-term healthcare facilities, healthcare personnel, the immunocompromised persons might need an additional dose, even not as a booster later on, but even they might need another series or another dose in their series. But these are all things, again, that are not been studied. So they're studying them now, but they've not been actually been recommended that occur. They're doing the studies for booster doses, though, because it's important that if they decide that they need to do it, then they have the data ready and available at the time that they can do it. The other issue that we're seeing a lot of is this mixing and matching. Can I get one vaccine and then get the other? And again, the FDA still recommends not mixing and matching if you can avoid it. But there are certain situations we've seen where people have not been able to avoid it. Perhaps they had a reaction to one of the vaccines, the first dose of one of the vaccines, or perhaps they accidentally got it administered. Or one of the things that I'm seeing now is people coming in from other countries who got one dose of a vaccine, and we don't have that vaccine available here, which, by the way, they recommend completing the series with one of our vaccines if that's the case. Don't memorize this stuff. If the clinical consideration that the CDC publishes has this all in great detail. So if you get that question, go back there and read that. But we are actually doing studies that we see that they're doing the studies on safety, immunogenicity, and public need. But right now, there's no data that says, yes, we need to go there, but the studies are ongoing. There are some legal issues about this also because of the fact that this is a emergency use authorization. But since we have a legal expert, Lisa, on the joining us here, I prefer her to talk about it, actually.
Yeah, that's great. Elisa, if you could join us and address the legal concerns, that would be great. Thank you.
Yeah, hi. I will put my legal hat on right now. Yeah, no, this is a real concern. So under the PrEP Act, the Public Readiness as Emergency Preparedness Act, that's the law that gave pharmacists the authority to do a lot of the things that we've been doing under COVID. And the key is it provides immunity from liability if we do it according to what's laid out in the guidance and the information from HHS. Giving a booster is not in an EUA, in the emergency use authorization, or in a licensed product or approved product. So you would be going outside of the bounds of the protection that we would get in order for liability immunity. So the bottom line is, if you give a booster, you're at risk for liability. So
along with that is the off-label issue too, is that you cannot write off-label on this type of thing until the vaccine is actually approved by the FDA. There's no such thing as going off-label.
Exactly. Yeah.
Well, that's very clear. All right, we don't want to break the law here. Okay, so let's go to the next set of slides here on practical advice. And Dr. Bridges, I'm going to ask you these questions. What tools and strategies are available to pharmacists and other providers to identify which vaccines patients need?
Thanks so much for that question. So there are actually a lot of tools out there to help with the first step in the standards for adult immunization practices, which is to assess patients' vaccination needs. Really, to do an assessment, you've got to get into the registry, the immunization information system in your jurisdiction. We know adult patients see providers in a lot of different settings, pharmacy, their primary care doctor, a lot of times occupational health settings and travel clinics and others. So, you know, as an immunization community, it's important for all of us to collaborate, make sure all those vaccines get put into the registry so that patients and all of the patients' providers have access to patients' complete immunization records. So that's number one, do an assessment. And there are a lot of tools. APhA, I'm sure, has one. Immunization Action Coalition has one. CDC has an online app and a patient quiz that patients can take and figure out which vaccines they might need and then talk to their provider about that. A lot of electronic health records also will have prompts and other tools to help providers. And of course, then, you know, again, your immunization information system in your jurisdiction also can help figure out which vaccines are needed when for your adult as well as for your pediatric patients. Doing that assessment and looking in the registry is even more important now than ever because COVID-19 vaccines were required to be entered into the registry. So a lot of patients will have their vaccine card. A lot of them, like some of my elderly relatives, may lose those cards. So you can't necessarily rely on that for COVID, but as we've been talking about, adult immunization rates are low and even lower because of the pandemic. So looking for all of those vaccines and figuring out what patients need and getting an immunization plan together, that's really important. So assessment is number one. And then the next thing, of course, you want to make a very clear recommendation for patients about which vaccines that they do need, administer the ones that they need. And if you don't happen to stock the particular vaccine, then refer them to someone else for remaining vaccines. And then again, as part of that immunization community, we all need to be putting our immunizations that have been given into the registry so that next provider that sees that patient has the most up-to-date information.
Those are great recommendations. Thank you for sharing those. I know a lot of pharmacists are trying to prepare, and as we've already talked about, a lot of changing recommendations. So you've got to know where to go to keep up to date.
Yes.
All right, so we'll go to the next slide here. Do you want to talk a little bit about this this information, Dr. Bridges?
Yeah, I think, you know, that communicating vaccines with patients, it can take a lot of time, but it's really important. And just a reminder about the critical role that pharmacists and other providers play in helping patients really understand which vaccines they need and why. So some patients will be very satisfied with just that recommendation from you about which vaccines they need, and other people need more information, both about COVID-19 vaccine as well as about other vaccines. So this is just one of those acronyms that can help you think about ways to help patients better understand the benefits of the vaccine specifically for them. So this is from the CDC website, but sharing tailored reasons. Some people, you know, a global message doesn't really help. They want something to understand specifically for them in their situation, why vaccine is beneficial. Having you highlight positive experiences that you've had with immunizations, talking about your own vaccination decision or that of your own family members, and then being able to address specific questions and refer patients to other information from credible sources can really help. And then really one of the messages that really works with patients too, what's important to them, is how immunizations that they get can help protect their loved ones. That's a really key message that patients need to hear. And then also talking about the costs of getting disease. So, you know, what's the cost of potential, usually very rare side effects from the vaccine versus what may be the severe consequences of getting sick or passing on that disease to somebody that you really care about. So I just wanted you to have this slide in case that was helpful for some of those patients that really want more information about that vaccine that's being recommended.
No,
and I
thank
think
you.
we're going to actually have a lot of issues this year because, again, we're fighting people who are going to say we don't have flu around, even though we had such a mild season. They're not going to want it. We have so many people right now that are staunch anti-COVID vaccines, which is carrying over to the other vaccines that they want too. And so it really is going to be quite a job for us to keep up and get this. And as Carolyn said, you know, we're busy, but we need to take the time to be able to talk to our patients about these important issues.
Yeah, I agree. I know that when I was in practice, I would, even if a person said no, you know, for a particular visit, I was always making sure to ask over and over and over. And it was surprising to me that maybe it was no today, but it wasn't a no tomorrow. And that really helped to get people through that hump. So it's really critical to keep asking. So I know we have one more slide before we enter the moderated discussion to share a little bit about the benefits and risks about COVID-19 vaccine. I think this is a great slide. So Dr. Bridges or Dr. Foster, if either of you want to speak about this one.
I think I can start just to let people know that you can find all of the slides from the Advisory Committee on Immunization Practices meetings. They're publicly available and are really a great resource. We pulled this particular slide out because I thought it was extremely helpful in helping patients and providers break down those rare, severe outcome risks from the different vaccines and by age group, because that risk for certain outcomes or severe complications does vary by age group and by vaccine and by gender. So again, the Janssen vaccine, they have been talking most recently about the risk of Guillain-Barré syndrome. And so you'll see that on the left, and that risk goes up somewhat with age. They have not found a risk of increased risk of Guillain-Barré with any of the mRNA vaccines. So that was really the more new information that was presented, regardless of whether you're looking at GBS or the TTS or the myocarditis, pericarditis cases. These are rare. And that's important to stress to patients, but for patients who are concerned, you know, this table, the information may help someone in a particular age group or of a particular gender decide, you know, which vaccine would be the best for them.
And this also is actually can prove to you that how closely the CDC and the FDA is monitoring for adverse effects. I mean, if we're picking up one case in 1 million doses, I mean, that's an extremely good system for looking for potential problems. So as Carolyn said, yes, they're very rare. And this slide will help you show your patients where, but also point out to them that the monitoring is extensive.
Yeah. No, this is great. Well, thank you for sharing that information. You can definitely see the difference in hospitalization, ICU, and death rates and numbers versus the cases of these events. So appreciate this information. So what we'll do now is we're going to go ahead and go into the moderated discussion. We will definitely address the questions that have been coming in the chat bar here in the questions bar. If you have any questions or comments, please feel free to add those. And I'll start with the first question that's listed here. Can you expand upon which vaccine we should be administering to senior patients? Is there a difference between the use of high dose and the adjuvant vaccines for this patient population?
I'll go ahead and take a shot at that one. Actually, there's no head-to-head comparisons of the two vaccines with each other, so that's not something that you can say one is better than the other. They're both recommended by the ACIP. They're both approved by the FDA for use in seniors, and so we know that seniors' immunity is not as good as younger persons. So even though they call out the use of this along with COVID, it's only called out because you just mentioned that there is some increased reactogenicity with it. But realizing the fact that seniors also do not react as much to it, so it kind of balances itself out to a degree. But yes, there's no recommendation still from ACIP that this vaccine should be used over a regular dose vaccine either. So it's really up to the, this is kind of where we've talked about in the past, is that this is shared clinical decision making through everything we do with vaccine. You talk to your patients, you talk about the advantages of what they want, and let them be involved in the decision of which vaccine they're going to get, but not to be avoided because of that.
Thank you. All right, and I have a question here related to just a little bit more information. Could you expand a little more on last year's flu season? Was it lower because we weren't testing as much for it, social distancing? How should we message to patients the importance of getting the flu shot if the season was mild last year? And I think you mentioned this, Steve, a little bit about, people might not want to take it because we didn't have such a significant flu season last year.
Dr. Bridges, take a shot at that one.
Yeah, I think it's important to just remember that not every country was able to do social distancing, do lockdowns, and we know that particularly in tropical areas, flu viruses tend to circulate year-round. So as much as I would love for influenza viruses to go away, that is very unlikely to happen. And they are still seeing some flu viruses through the global surveillance. There's a very large worldwide network of laboratories that does surveillance for influenza viruses. So while disease was quite low, historically low, there were still places in the world where influenza viruses continue to circulate. And I think as COVID-19 has aptly demonstrated again, these kind of respiratory diseases and transmissible diseases literally are just a plane ride away. And we're already starting to see diseases like respiratory syncytial virus, RSV, go up by quite a bit. You probably heard in the news, people having their summer colds, as people start to gather. So, the best vaccine obviously is the one that's given before you get exposed. Vaccine doesn't help you after you've already been exposed for flu. So, prevention. We want people to get vaccinated before the potential for exposure.
Yeah, that's a great point. And I have, seen people now that are starting to talk about the cold they hadn't had in a long time because they were using masks, washing their hands, and hopefully we can start picking that up again and impact that so it's not as bad this year. There's a great comment here. There are some patients who have been entered into the IIS but are not showing up because of technology glitches in the state registry. Could you reiterate the use data available and ideally check IIS, the cards, patient history, and use 15 to 30-minute waiting times to provide information about other vaccines that might be needed? So it's not so much a question, but just a comment about the importance of that information and gathering. And as you mentioned, Dr. Bridges, just sharing with each other is really important in assessing a patient's vaccine information. Great. All right, let's see. We've got a few more questions coming in. Could you address again the concerns we are hearing regarding amplification of reactogenicity when administering shingles vaccine with COVID?
Other than, the anecdotal report, I have not seen anything in publication about that. But we do know that shingles vaccine is pretty reactogenic, and people, somewhat similar to the mRNA vaccines or the J&J vaccine, can feel pretty wiped out the next day and be very fatigued, sometimes have fever, muscle aches, etc. So, where possible, someone's reliable, have them come back, as opposed to giving those at the same time. But if they desire it and they need to get up to date quickly, then you can just warn the patient, and again, encourage them to report to be safe, and also report back to you, depending on the kind of symptoms that they have, so that you can also report back to the vaccine adverse events reporting system. So that's going to be the best way that we really get some robust data about potential increased reactogenicity with giving those two vaccines at the same time. I know, Steve, if you have more information.
As the senior representative in this group here, yes, I've experienced the reactogenicity. But however, that's the whole thing, is that if I knew ahead of time that it was going to happen, then I'm not blindsided by it. You can't just give a person a vaccine, and this applies to any vaccine, without telling them they may have a reaction to it. And so the fact is that if the reaction, if you explain to them, you are going to have more of a reaction to this, because of the fact that seniors don't react as much. So in order to make this vaccine 100% effective or 98% effective, we've got to add stuff to it, like an adjuvant, to make it happen. So we're expecting this. And I think most people, if they know that happening ahead of time, even though it does hurt and it does turn red, they won't react as much to it personally from it.
That's good. That's
Mentally,
good.
yeah.
No, it's a good point. Knowing what to expect is very helpful for sure. Here's a great question that's coming in related to myocarditis. Is there any data on myocarditis in the 12 to 17 age group, male versus females? It said that I noticed that the ACIP only referenced greater than 18 years of age or older.
Yeah, that's a really good question. I have not seen any data on the younger age group, that 12 to 15 years presented, and
I think most of that was because of the data was we hadn't approved the vaccine for that younger age group at that point, so we really didn't see a lot of cases in there, because it had only been the 12 to 17 year olds that had only been getting it for a short time. So they're monitoring for it, but I don't think they had the information.
Yeah, so they're doing regular updates, as Steve says. So I think we will just continue to follow.
Okay,
well, that.
Perfect. Thank you. And then here's a question on pregnancy. If flu vaccination recommended to pregnant individuals, no matter I think which trimester, the recent updated information focused on third trimester. Could you please clarify that recommendation?
Yeah, so that's a great question. So you can get influenza vaccine during any trimester. So it's different from the Tdap vaccine, where you want to, ideally during that, 27 through 36 week gestation is the ideal time for the Tdap. But for influenza vaccine, it's any time during pregnancy. But I think their point was that really, if someone's in their third trimester and you're going to see them, and they may already have given birth by September or October, go ahead and give them that flu vaccine in July, August, if you happen to see them, so that that baby can get that passive immunity through the mother's vaccination. So you don't want to miss opportunities to vaccinate pregnant women, even if it's in that, July, August time frame. So that's just one of the groups where that, wait until September kind of language may not apply, because we know that passive immunity, when you vaccinate pregnant women, then those babies for that first 6 months of life, particularly the first 4 months of life, have substantially reduced risk of influenza and influenza hospitalization in the infant. So don't miss an opportunity to vaccinate those pregnant women even in July or August if they're in that third trimester.
And it's the third trimester where you actually pass the immunity onto the baby. Up until now, we've been more. It was very concerned about the mother, and this is really about the first time I think we've talked about the passive immunity that goes on. So if someone is pregnant in their early trimester, you can still wait till September and October to give it to them, so that the duration for them lasts longer also.
Yeah, there is some good data that really kind of, regardless of the trimester where pregnant women are vaccinated, the infants get protection. So, but certainly the risk of the severe complication from influenza in the pregnant woman goes up with increasing trimester. So her the mom's potential risk of the severe outcome from influenza if she becomes ill during pregnancy is highest for her in that third trimester. So, similarly, if you can vaccinate them before that third trimester when their risk goes up, particularly during the flu season, that's better for the mom. And it appears that it doesn't make a substantial difference for the infant in terms of when the mother gets vaccinated during the pregnancy. So I hope that's clear as mud.
No, thank you for the additional information. There's some nuances there people are trying to, I'm sure, capture. And then there's a question here, and I know Mitch posted this morning on Engage, but definitely want to address this one. Could you comment on the recent FDA CDC announcement on the J&J COVID vaccine expiration extension? So again, more breaking news, but wanted to see if either you, Mitch, or either of you, Dr. Foster or Bridges, wanted to comment on that extension.
It was just an extension from 4.5 months to 6 months as far as expiration dates go. And it was, again, more studies on as they come out every day. And by the way, Mitch does a great job of posting all these changes on a regular basis. So if you're not keeping up with the APhA announcements coming up, please do that. But it is, as the studies go on, we're going to find out these vaccines are more stable and they can actually do that. I want to add one overall thing to this whole discussion, though, is the fact that when pharmacists were given the authority to go ahead and give vaccines and all this, you got to realize that we can't tell you every situation that's going to occur with this. There has to be some common sense that goes along with what you do with your patients. You have to be able to make a decision along with the patients based on their particular circumstances. So no matter what you do, you're not going to find every situation going to have an answer. And right now we have a lot of lack of answer just because of the fact that not all the data is in yet. So just be aware that you're going to have to make some decisions on your own as to what you do. Just make them legally.
Yeah, no, great point. Clinical decision making, concordance with the patient, the discussion is really, really important. And I have, we have a couple more questions here, but one of them I wanted to ask you, Dr. Bridges. I know you mentioned you have a college student getting ready to go back to school. What can pharmacists do to help for that? And I know in our discussion, as we were preparing, I was thinking my own daughter, who's a senior, I'm like, oh my gosh, I have to make her appointment so that we can see where she's at and make sure she's all caught up. But any recommendations for pharmacists on this particular topic?
Yeah, I think it just gets back to that, adult immunization practice standards, helping by doing that assessment, helping look into that registry, see where they are, what they're missing. The registries, should be very helpful in helping pharmacists and physicians and others predict which vaccines are needed, and providing that counseling, meningococcal vaccines, the MenB vaccine, the Tdap, make sure they're up to date on their HPV vaccines, that they get their flu vaccine, and then also that they have had their COVID-19 vaccine, or at least get counseling about that so that they know what's recommended for them. So that assessment is really important, and that registry can really help you with that vaccine needs assessment as well.
And I have another question that popped up related for college students. For college students, is giving the flu vaccine in August too early? If need before go on campus, is that reasonable to do?
Yeah, I think this is one of those situations where, again, the issue of waning immunity is most pronounced for older adults. And so, you know, if there, a lot of college campuses are going to have vaccination clinics on their campuses. I think a lot of them do that, partner with providers in their community to do so. But if you don't know, or the patient wants to go ahead and get vaccinated in August, and you've got the vaccine and they're there, you know, it's not the college student that have as much of a concern about that waning immunity. So they certainly could get their vaccine in August.
Great. Well, I want to thank the both of you for joining us on this 50th webinar. I really appreciate all the information and your time, and thank you for keeping us up to date. And thank you for everything that you've been doing during this time. So again, thanks a lot for your participation. And I just want to remind the audience again that we have the handouts right in that toolbar for you to download. What we'll do now is we're going to review APHA's activity and what's coming. So thank you again, Dr. Foster and Dr. Bridges, and we appreciate it.
Thank you.
Thanks for having us.
All right, so what we're going to talk about next is just some of the available practice resources that are out there for all of you. A lot of information was shared today, and APHA has done a great job of pulling practice resources together to update you on the latest information. So some of the items that are listed here are things to consider reviewing. We have an adolescent COVID-19 vaccination, frequently asked questions about the use and safety of the Pfizer-BioNTech COVID-19 vaccine in individuals between the age of 12 and 15 years old. And there's a lot of questions coming, and I know a lot of you have questions about younger kids. When are those vaccines coming? So we are trying to update them as soon as we have information. We also have a vaccine summary chart, a reference that compares key information about Pfizer, Moderna, Janssen COVID-19 vaccines, and summarizes the CDC's clinical considerations. There's also the vaccine microsite for pharmacists, and on this site we have accessing resources, talking points, other information to empower pharmacists to build vaccine confidence. And hopefully you've seen some of the great videos that have been done with pharmacists in different practice areas that you can share on social media, that you can share with your friends and family. And those are great videos, very, very incredible work that pharmacists are doing out there in different areas. We also have new education coming. In the next slide, we have the new 15 on COVID-19 webinar, which is a short CE video series. The latest episode covers the variants and what pharmacists need to know about the impact on therapy and vaccine efficacy in 15 minutes. So this is a great resource, and it's a quick review in 15 minutes. So hopefully you have a time to listen to this. And we have other CPE that's available in the links provided. We also have the Engage platform, where you can ask attendees to continue the conversation by posting on Engage to the pharmacy responses on the COVID-19 community. And as you might have seen this morning, Mitch updated us on the extension information. There's other information that's coming up. It's a great way to keep up with the conversation and then share your own experiences out in the field about what you're doing, what's working for you, some tips on vaccine hesitancy and what might work with your community. In the next webinar, we will be discussing on Thursday, August 12th, will be the review of the symptoms of common respiratory illnesses and how pharmacists can triage and care for patients who present with these symptoms through testing, treatment, and vaccination services. And again, CPE will be available for this, and the registration is coming soon. So today's webinar recording will be available in the Open Forum webinar library as soon as it's finalized. But again, thank you so much for participating in the last 50 webinars. It's been a great opportunity to have information sharing and to have these speakers come and share their knowledge and their time. We thank you for participating today, and we hope to see you on August 12th. Thank you so much.